Appropriations Subcommittee on Labor, Health, Human Services, Education, and related agencies will come to order. Secretary Azar, thank you for being here again this morning and for our efforts to work together that while they could always be better, I think we're about to get you staffed up to a point that will no longer be the excuse. So we'll think of what comes as the next reason this is not working the way it should. But I wanted to encourage you to continue to do that. Obviously, this is a difficult budget for us to talk about, and frankly, I think it's a difficult budget for you to defend, and we'll see what we have to do here. The Budget Control Act has impact on this. In the case of the budget that you have been asked to submit, there's a reduction of 14%. The Budget Control Act would require an overall reduction in the non-defense discretionary spending of 9%. So this budget exceeds even that. I would say for the 9%, as I mentioned last week with the Education Secretary, President Trump didn't sign the Budget Control Act. President Obama did, and you didn't vote for it. And most of us who were here when we did the Budget Control Act did. So there's some shared responsibility in where that decision has led us. But there'll be a number of concerns that I imagine you have to share about what this budget asked for. We've made a top priority in the years I've been chairman of this committee, ensuring that medical research has the resources it needs at this particular time of real breakthrough potential to do what it does in a way that saves lives, improves lives, and frankly benefits taxpayers as we find more solutions. As an example, if we could find a way to identify Alzheimer's and delay onset by 5 years, we'd cut the projected cost for Alzheimer's by a third between now and 2050. The cuts that you're proposing for NIH would be an overall cut of 12.6% in research, or almost $5 billion. I'm sure that's not going to happen, but for that not to happen, we have to have a number to work with that you don't have to work with yet, and I believe we'll have that number. We're not going to eliminate LIHEAP funding that provides 6 million households with heating and cooling assistance. This cuts resources that train lots of people for medical professions and behavioral health and pediatric dentistry, and we're not likely to do any of those things. I understand you had to make difficult decisions here. I do appreciate the two new initiatives that you've proposed, and I'll be supportive. I believe the committee will be supportive of those. One, to eliminate the transmission of HIV in the United States by 2030. Phase one of the 10-year plan would infuse the hardest hit states and communities. Missouri is one of those, with additional resources, additional expertise, additional diagnostic and treatment options, and I'm pleased to see that that's a new proposal, as is the new pediatric cancer program to provide $5 million over the next decade to launch a major data project on childhood cancer. Now, that runs pretty dramatically in the face of cutting overall NIH funding, but I do think it gives us the opportunity to look even closer at pediatric cancer and factor that in as we continue to hopefully improve NIH funding. In addition to these new programs, I believe that mental health treatment needs to be treated as any other health issue, and the budget request includes level funding for the certified community behavioral health clinics. Missouri is one of the 8 pilot states in those clinics, and 200 locations in our state treating behavioral health like all other health, and we need to do more to encourage that. The head of Barnes Jewish Hospital told me just last week, he said, quote, "I can't treat a person's diabetes until their schizophrenia is under control." And I believe we're going to find that if you do treat behavioral health like all other health, you actually save more money on the other health care cost than you spend doing the right thing in behavioral health. Finally, the administration's commitment to ending the opioid epidemic is well reflected in this request. According to the Council of Economic Advisors, the total economic cost of the opioid epidemic in 2017 was $684.6 billion. The cost to our economy, the cost to families of the opioid epidemic was that. According to the Missouri Hospital Association, this estimate suggests the epidemic cost the U.S. nearly $1.6 billion every day, $21,700 every second of every day through 2017. The past 4 years, this subcommittee has increased funding to combat the epidemic by more than $3.5 billion, and we have had great bipartisan leadership on this of people who really, on both sides of where I'm sitting, understand how this has impacted their states and have forcefully made that case. I appreciate what you had to do to try to prioritize limited resources. We will try to do things that make those resources more realistic. And I'm glad you're here today, and glad you bring all the expertise and ability you bring personally to this job. And I'd like to turn to my partner here in this effort, Senator Murray.
Well, thank you very much, Chairman Blunt. Welcome, Secretary Azar. People across the country made pretty clear last November that they want us to fight for their health care and make sure families get the care they need. That means fighting for protections that allow people with pre-existing conditions to get quality, affordable health coverage. It means fighting to bring down the skyrocketing health care costs. It means fighting for public health investments that keep our communities safe and address crises like the HIV and opioid epidemics. And it means fighting for investments in research that can help discover new treatments, save lives. But instead of fighting to defend people's health care, President Trump is fighting in court to take health care away from millions of people who are covered through the exchanges, covered through Medicaid, and are covered by their parents' plan. Instead of fighting to bring those costs down and help people get the care they need, he is fighting in court against protections for over 130 million people with pre-existing conditions, for bringing back annual and lifetime caps on benefits, even for people who get their insurance through their own job, and for letting insurance companies offer plans that don't cover essential services like maternity care or prescription drugs. And President Trump's budget before us is cut from that same cloth. It bulldozers right over the concerns of families with proposals that would make it harder for people to get care, and cuts that would undermine the well-being of families across the nation. Overall, this budget proposes a deep $12.7 billion cut to the Department of Health and Human Services, slashing it by 14%. I always say a budget is a reflection of your values. Well, like many of his actions, this budget tells a very different story about President Trump's health care priorities than his empty promises. Despite claiming time and time again he would fight for people's health care, and despite his recent claim Republicans would be the party of health care, President Trump is continuing to push for harmful policies that would weaken patient protections, take coverage away from people, and put needed health care further out of reach. This budget includes Trump Care, which the Congressional Budget Office estimates would kick tens of millions of people off their health insurance. When it comes to curbing the HIV and opioid epidemics, President Trump promised to fight the fire, but his budget actually fans the flames. It would make these crises far worse by cutting over $1 trillion from Medicaid over the next decade and repealing Medicaid expansion. Medicaid is the largest source of insurance coverage for people with HIV, covering more than 40% of people with HIV in care. And the 37 states that expanded Medicaid show how it can play an important role in addressing the opioid crisis as well. In some of these states, as many as 4 out of 5 people receiving treatment for opioid addiction are insured by Medicaid. The Centers for Disease Control and Prevention also plays a very important role addressing these public health crises and many others, yet the Trump administration proposes cutting its budget by 1/10. This proposes cutting immunization efforts by $78 million, even amid an alarming measles outbreak in my home state and several others. It proposes cutting work on birth defects and disabilities by $44 million, and proposes cutting efforts to combat antibiotic-resistant pathogens and emerging infectious diseases by $103 million, despite the World Health Organization labeling AMR, quote, one of the biggest threats to global health. And when it comes to medical research, this budget is a small step forward and a marathon sprint back. I do applaud the administration's call for more pediatric cancer research. For every new penny President Trump proposes for pediatric cancer research, however, he proposes cutting $1 from the National Institutes of Health. Cutting medical research by 13%, as he proposed, would slow our efforts to advance our understanding of Alzheimer's disease, develop vaccines for HIV and flu, and treatments and cures for every other kind of cancer. And at a time when our nation is facing a health professional shortage, it's proposing to cut almost $800 million from healthcare workforce training programs that support tuition assistance, loan forgiveness, and training for several 100,000 health professionals annually. This budget also continues the Trump-Pence administration's harmful trend of putting ideology over women's health and reproductive freedoms. Its language specifically excluding Planned Parenthood from federal funding is just one of the many alarming steps backwards for women's health care from this administration. Another is the recent announcement stripping Title X family planning funds from several qualified Planned Parenthood affiliates, despite their proven record, helping millions of people struggling to make ends meet, get birth control, cancer screenings, and other basic health services. Another example is the administration's gag rule, which will push Planned Parenthood out of the program altogether, interfere with patients' ability to learn about their full range of reproductive care options, and prevent people from across the country from getting the care they need with the providers that they trust. Once again, the Trump administration proposes eliminating safety net programs that provide critical assistance to millions of vulnerable families, like the Low-Income Home Energy Assistance Program, which helps families afford heating and cooling, and the Community Services Block Grant, which gives states resources to address the challenge of poverty, and eliminating funding for preschool development grants, which provide high-quality preschool to tens of thousands of families. It's clear that we are facing a child care crisis in this country. Parents struggle every day to find and pay for high-quality programs. We need more investments in that, not cuts in early childhood education. And this budget continues to show disregard for families fleeing violence and extreme poverty in Central America. This budget proposes a gimmicky $2 billion contingency fund on the mandatory side for the Unaccompanied Children Program, in addition to the base discretionary appropriation. Let me be clear. I want to make sure that every child in HHS custody is well cared for. But I have been deeply disappointed in President Trump's treatment of migrant children, from heartlessly separating children from their parents to attempting to undermine protections for migrant children. And I have been frustrated with your department for failing to sound the alarm on the lasting damage that family separation would cause, sharing information with the Department of Homeland Security so they can target potential sponsors for deportation, and relying heavily on unlicensed temporary facilities, which are 3 times as expensive as permanent beds in licensed centers. To say nothing of my concern that the Office of Refugee Resettlement was tracking young women's reproductive health, and that former Director Scott Lloyd was personally interfering with young women's decisions about their bodies. Finally, Mr. Secretary, I am concerned by a recent proposal you outlined in a letter to my office to restructure the Office of the Assistant Secretary for Health. That restructuring would impact programs that serve adolescents, women, low-income communities, and more. And I'm very concerned that that proposal, much like this budget proposal, would serve very little purpose beyond prioritizing ideology over the health needs of families in this country. Mr. Secretary, finally, I just want to note, it is inaccurate to claim the Budget Control Act requires the President to submit his budget at sequestration levels. In fact, just 2 years ago, President Trump's budget proposed an increase to the caps for defense spending. So I hope you don't rely on that excuse for decisions in this budget. Thank you very much, Mr. Chairman.
Thank you, Senator Murray. So, Secretary Azar, you and I have talked about the oh, I'm sorry. We want your, I'm sorry. I'm so eager. I have so many questions I want to ask here. Maybe you want to waive your opening statement. Go ahead with your opening statement.
Well, thank you very much, Chairman Blunt and Ranking Member Murray. Thank you for inviting me to discuss the President's budget for fiscal year 2020. It's an honor to have spent the year since I last appeared before this committee, leading the Department of Health and Human Services. The men and women of HHS have delivered remarkable results during that time, including record new and generic drug approvals, new affordable health insurance options, and signs that the trend in drug overdose deaths is beginning to flatten and decline. The budget proposes $87.1 billion in FY 2020 discretionary spending for HHS while moving toward our vision for a healthcare system that puts American patients first. It's important to note that HHS had the largest discretionary budget of any non-defense department in 2018, which means that staying within the caps set by Congress has required difficult choices that I'm sure many will find quite hard to countenance. I know that members of this committee have delivered strong investments in HHS's discretionary budget in the past, especially at the National Institutes of Health, and I want to be clear that HHS appreciates this work over the years. Today, I want to highlight how the President's budget supports a number of important goals for HHS. First, the budget proposes reforms to help deliver Americans truly patient-centered, affordable care. The budget would empower states to create personalized health care options that put you, as the American patient, in control and ensure you are treated like a human being and not like a number. Flexibilities in the budget would make this possible while promoting fiscal responsibility and maintaining protections for people with pre-existing conditions. Second, the budget strengthens Medicare to help secure our promise to America's seniors. The budget extends the solvency of the Medicare Trust Fund for 8 years, while the program's budget will still grow at a 6.9% annual rate. In 3 major ways, the budget lowers cost for seniors and tackles special interests that are currently taking advantage of the Medicare program. First, we propose changes to discourage hospitals from acquiring smaller practices just to charge Medicare more. Second, we address overpayments to post-acute care providers. And third, we will take on drug companies that are profiting off of seniors and Medicare. Through a historic modernization of Medicare Part D, we will lower seniors' out-of-pocket costs and create incentives for lower list prices. I believe there are many areas of common ground on drug pricing where we can work together to pass bipartisan legislation to help people. The efforts we've proposed around taking on special interests in the Medicare program are so sensible and bipartisan, in fact, that even the New York Times editorial board praised these ideas last week. We also protect seniors by transferring funding for graduate medical education and uncompensated care from Medicare to the General Treasury Fund so that all taxpayers, not just our seniors, share these important costs. Finally, the budget fully supports HHS's 5-point strategy for the opioid epidemic: better access to prevention, treatment and recovery services, better targeting the availability of overdose-reversing drugs, better data on the epidemic, better research on pain and addiction, and better pain management practices. The budget builds on appropriations made by this committee and provides $4.8 billion toward these efforts, including the $1 billion state opioid response program, which we have focused on access to medication-assisted treatment, behavioral support, and recovery services. The budget also invests in other public health priorities, including fighting infectious disease at home and abroad. it proposes $291 million in funding for the first year of President Trump's plan to use the effective treatment and prevention tools that we have today to end the HIV epidemic in America by 2030. HHS also remains vigilant on other public health challenges, including the current epidemic of teen use of e-cigarettes. In fact, I'm pleased to announce that today the FDA is issuing warning letters to companies for making, selling, or distributing liquids used for e-cigarettes that have misleading labeling or advertising that resembles prescription cough syrups. The Trump administration supports a comprehensive, balanced policy approach to regulating e-cigarettes, closing the on-ramp for kids to become addicted to nicotine while allowing for the promise of an off-ramp for adult smokers of combustible tobacco products. This year's budget will advance American health care and help deliver on the promises we've made to the American people. And I look forward to working with this committee on our shared priorities, and I look forward to your questions today. Thank you very much.
Well, thank you. Now we'll get to those questions. And I'm hopeful that we can get through most of our questions by the vote and leave sometime shortly after 11:45. But if we don't, I'll come back. And there'll be a second round of questions for anybody that wants it. So I would ask everybody, including me, to stick with their time limit. So the first question I almost got into a moment ago is just about the new liver allocation policy, the solid organ allocation policy, something that Senator Moran and I have been very interested in. We had one meeting with the Organ Transplant Procurement Network group, and frankly, our view of that meeting was very different than what they finally did. Both the University of Kansas and Washington University are really among the leading stakeholders in this in terms of the transplants that they're part of. I guess the problem is that states in the Midwest, states in the South, states that have lots of small communities tend to be much greater organ donors. And obviously, as long as we had a regional view of this, that was a benefit to their neighbors. There's been a dramatic decrease in availability of lung and liver transplants at Barnes Hospital, at least, since the new policy went into effect. And it's my question. I think there'll certainly be a lawsuit filed here. Will you commit today that you'll ask OPTN, the transplant group, not to move forward with this controversial policy until that lawsuit has been dealt with?
Well, Mr. Chairman, I am concerned about the liver allocation policy issues you raised. There, frankly, any transplant organ allocation policy issues are quite difficult politically and as a matter of public health. And I received a letter from you and many others about the most recent the liver transplantation allocation policies out of OPTN. And we requested of them to think again and to ensure, especially, I believe it was it the Kansas and Missouri providers, that we wanted to ensure, especially that comments that came in at the last minute or perhaps came in late were fully considered by OPTN. We recently received a letter back in response to my challenge to them, which I believe your staff has access to, where basically they said they went through the procedures, they considered all of the comments, and they remain steadfast in their conclusion regarding the science and technical aspects of the allocation decision they made. I do believe my cards are played out here. Congress deliberately set up the OPTN system to keep people like me from actually dictating the policy allocations, but I'm happy to work with the committee on any other solutions here to look at and ensure that the fair and scientifically valid treatment has been given here.
Well, I would think that one of the reasons the old system worked was that people were more encouraged to be donors if they believed that people in their community would benefit from that. On liver transplants, under the new policy, we think there'd be 32% fewer transplants in Missouri. I think Barnes Hospital's number 4 or 5 in the country in transplants, and they have told me since this started they're now having to send teams of doctors across the country to get organs that would have been available under the old policy locally. I think it's further complicated and added expense and precious time to the system. We're going to continue to watch that. Let me ask one more question here on a big issue, and that's your role in providing security and taking care of unaccompanied children. You have nothing to do with border security, but you wind up with great responsibility. Would you talk about how that's changed in the last few months?
Absolutely, Mr. Chairman. We're in a tremendous crisis at the border right now. We are getting 300 to 350 unaccompanied alien children crossing the border and referred to HHS every single day right now. These are 10, 12, 13, 15-year-old kids. They're not coming with parents. They're coming across the border by themselves. And these are historic levels for us. That's a 97% increase in February from the previous year, February. It's just not sustainable at this rate. I know the ranking member raised in her opening statement concern about temporary influx facilities. I will work with this committee to do anything we can to take care of the children appropriately. Any ideas you have how to ensure that we're doing that well? I would love to enhance our fixed permanent capacity. It's cheaper. It's more economical. We've been working on that. It's slow to do. You understand government procurements and government contracting around leasing is slow. We need help. We need help. And at this rate, the funding even for this year will not be satisfactory. And I want to be transparent with this committee in particular about that. We are working with OMB on what those total funding needs could be at the current rate, but it would exceed where we are even with the transfer and reprogramming that I notified the committee about. This is just, it's beyond belief the level of children that are coming across the border right now.
In your case, the unaccompanied children.
These are unaccompanied children. These are kids just coming across. They don't have a parent with them. They're coming by themselves.
All right, I have more questions on this, but I'm going to stick with my time restraint. I have a feeling they'll be asked by others. If not, I'll ask them when we get to another round. Senator Murray.
Oh, thank you. Thank you, Mr. Chairman. Mr. Secretary, despite continued assertions that your budget guarantees affordable health care and protects people with pre-existing conditions, the fact is that the administration is doing everything it can to actually sabotage health care, and this budget appears to be just more of the same. This budget continues to push harmful policies that undermine health care for millions of people across the country. Your budget calls for repealing and replacing the ACA with the failed Trump Care bill, which was rejected last Congress. And in his clearest message yet to patients and families that he sees their health care coverage as nothing more than some kind of political football, last week President Trump sided with the ruling that all of the ACA should be struck down, all of it. Now, according to reports, you initially opposed President Trump on that and issued a statement of support. So I wanted to ask you today, did you initially object to the president's decision to side with the Texas court because you know the impact that this would have? It would be devastating for so many families?
As you can appreciate, the advice of a cabinet member to the President of the United States is highly confidential, and it wouldn't be appropriate for me to comment on that. What I would say is, the position the administration took in the Affordable Care Act litigation is an appropriate position. It is supporting a district court's decision. Reasonable minds can differ on this question of legal issues. This is not our policy position. That is a legal conclusion about the ACA, and that litigation, which we did not bring. We're a party, I'm the party, in the litigation, but we want to protect pre-existing conditions. If the litigation ends up in that position, we want to work with you to secure better care for people and make sure all the types of issues you've raised are taken care of in any kind of new legislation.
Well, let me just ask you, as Secretary of Health, do you agree that if this ruling is upheld, as the administration is arguing for, it will result in tens of millions of people losing their coverage and allow insurers to discriminate against people with pre-existing conditions if it's upheld?
Well, the burden would be on us to work together to actually come up with a better care plan. That's a different
not the question. The question is if the court goes through with the ruling as you have requested them to, will it result? Nothing else happens.
Well, you wouldn't have Medicaid expansion and you wouldn't have the exchange subsidies, and we
And
would work with you to
pre-existing
come up with a
conditions.
better system that actually we hope
And
delivers better care for people.
I've heard that before, but it would mean that people with pre-existing conditions would lose their.
The president will never agree to any legislation that doesn't protect people
I'm
with
not
pre-existing
asking about
conditions.
legislation. I'm asking about the court decision.
A legal interpretation of a court case is not a policy position about what we want to have happen for people with pre-existing conditions.
Well,
We're going to fight for people with pre-existing conditions under all circumstances, but a legal judgment filed by the Justice Department is different than a policy position to work with you to protect people with pre-ex.
okay. Well, it's pretty clear. If the administration goes after this in court and wins, people will lose their pre-existing conditions at that point. So let me just go on. I wanted to ask you about Title X, and as you know, I am really concerned about this administration's constant efforts to undermine the historically bipartisan Title X family planning program. It's the only federal program dedicated to contraceptive health care and family planning services, and actually helps 4 million people annually get services like cancer screenings, contraception, crucial preventive health services. Your Title X domestic gag rule will take effect very soon, and it will bar providers from talking to their patients about all the family planning options. The American Medical Association has actually called that rule, quote, a violation of patients' rights under the Code of Medical Ethics, unquote. And they've actually joined Planned Parenthood to fight that in court. You also announced the Title X grant recipients for 2019, dropped 5 Planned Parenthood affiliates, make it harder for tens of thousands of women to get the care they need, and instead awarded funding to an ideologically driven organization that doesn't even offer FDA-approved birth control. And you notified, as I mentioned earlier, your intent to reorganize the offices that administer both the Title X and teen pregnancy prevention. So I just have a few seconds left. If you can answer yes or no, I wanted to ask you, is birth control an evidence-based family planning option?
We support the full range of family planning. That's why we fully funded and kept it flat, kept the Title X program flat funding, even as we cut other parts of the budget. So we do support access to contraception and birth control and the full range of family planning options.
And you believe that birth control is an evidence-based family planning program?
It's part of the Title X program, and we support that.
Well, should HHS award scarce federal funding, family planning dollars to entities that do not prescribe or provide birth control?
So the one entity that you're referring to actually, as part of its grant application, is required to have there are going to be 7 federally qualified health centers that are actually part of their. These are always done as a program with a grantee and sub-grantees. So they have to offer across the program the full range of family planning alternatives required by statute,
including birth control.
Yes. So they will have other providers in there, the 7 FQHCs
So it'll
that
make
are
it
part
harder for women. They got to get pushed around. I get it. Okay. All right. And my time is out.
Thank you, Senator Murray. Senator Alexander.
Thank you, Mr. Chairman. Welcome, Mr. Secretary. Let me first pass a compliment to Senator Blunt and Senator Murray, the ranking member, and to other members of the subcommittee for 4 consecutive years of significant increases of funding for the National Institutes of Health. We see the results of that everywhere, and I fully support it, and I thank you for your leadership. Senator Murray, Senator Durbin, and you have been consistent supporters of that. Second, to the President and to you, I'm proud of the initiative that seeks to reduce HIV infections by 75% in the next 5 years, 90% in the next 10 years. I hope you will focus especially on those parts of the country where that's a special problem. African Americans account for 43% of HIV diagnoses. In 2016, more than 84% of the people in Memphis in HIV were African American, and of the estimated new HIV diagnoses in Tennessee, more than 25% were in Memphis alone. And I want to call to your attention the Medicare Area Wage Index, which I won't ask you a question about, but that's continuing to be a reason why hospitals, especially in rural Tennessee and other parts of rural America, close because of the unfairness of that index. Now, Mr. Secretary, I heard the question by the senator from Washington about the Affordable Care Act. I think it's a pretty far-fetched case, in my opinion, but I'm not the judge. I'm pretty sure that if there were any decision that resulted in the Affordable Care Act being overturned, that the court would stay the effect of the decision, giving Congress and the president time to do whatever they wanted to do. But let me ask you this question. Have you made any changes in the way you are administering the Affordable Care Act as a result of the Department of Justice's position on this litigation?
We have and will not make any changes to how we administer the Affordable Care Act in light of the litigation. It could be a year, 2 years before we get any final ruling by an ultimate final court of jurisdiction. I have instructed my team, my organization, we continue to implement the Affordable Care Act faithfully and fully across the board without regard to litigation positions taken by the administration in court.
So whether you like it or not, you recognize it's the law.
Absolutely.
On a separate question, the committee that I'm chairman of and Senator Murray is the ranking member, the Health Committee, have been working with the Finance Committee, Senator Grassley and Wyden, for the last several months to see if we could identify a series of steps to reduce health care costs. Testimony before our committee is that up to half of health care costs are unnecessary. We're working on that the same way we worked on opioids, which means Democrats and Republicans working together, various committees working together, staffs working together. So far, so good. Our goal in the Help Committee is to see if we can produce a recommendation, a markup for the full Senate by June or July. Are you and the administration willing to work with us and support our efforts to address these issues like surprise medical bills, prescription drugs, direct primary care, transparency, rebates, other issues? If we're going to work in a bipartisan way, is the administration willing to support our efforts to get a result in this way?
We are fully supportive of the efforts of you, Senator Murray, Chairman Grassley, Senator Wyden, working together on a bipartisan basis across all of those issues.
On opioids, President Trump asked the president of China to make all forms of ethanol illegal, and China has announced and China has announced that it will do that starting May the 1st. I want to congratulate you and the president for that and thank the officials of China for that, because our Drug Enforcement Agency has told us that one way or the other, most of the fentanyl that comes in the United States starts in China. I don't have time for you to answer a question, but as we think about opioids, I hope that you will keep an eye on the effect it's having on people with pain. While we're getting rid of opioids that are used inappropriately, we want to make sure that they are used appropriately by doctors, and the CDC guidelines, about which there will be a report in May, and the FDA report in August, should be seen as advice and guidelines, leaving the decisions in the hands of individual doctors, and I hope you will help us do that. Thank you, Mr. Chairman.
Thank you, Senator Alexander. And I'd want to say that having you and Senator Murray on this committee on things like the health care issues and things like moving forward on NIH research makes a real difference. Having both of you here who also have the authorizing committee, and your leadership's really mattered, particularly on what we've been able to do at NIH, and nobody's been more involved in that than Senator Durbin. Senator Durbin?
And congratulations to you and Senator Murray. This 4 years of consistent 5% real growth at NIH is saving lives. The president's recommendation of making a cut in medical research, I believe, will be roundly dismissed by both political parties, and I hope that that's the outcome soon. I thank you all, including Senator Alexander. So, Mr. Secretary, I have so many questions, so little time, as they say. Let me go to this unaccompanied children issue for a minute. When I asked the Inspector General to investigate the zero-tolerance policy of the Trump administration, which forcibly removed over 2,800 children from their parents when they came to the United States, we were told that, in fact, the public announcement of this program actually postdated the initiation by as much as a year, that there could have been thousands that had not been disclosed prior to the announcement. When did you first become aware, Mr. Secretary, of the President's zero tolerance policy?
So I became aware of the Attorney General's zero tolerance initiative basically when he announced it in the public. I learned of it in the media in April when the zero tolerance was announced at that point. Then subsequently, as we have been going through this, I believe in the summer or late summer, whenever, maybe it might have even been through the Inspector General's work that you asked for, learned of some of the previous piloting or demonstration work that may have been occurring, a lot of it prior to my even arriving at HHS.
How many children were affected by this piloting or demonstration effort?
Well, as the Inspector General said, there was a surmise there only of numbers. There's no, the Inspector General just said that there could be a couple of thousand, but didn't know how many in that case.
Did you play any role in crafting this policy of zero tolerance?
No. How could I if I learned about it in April when it was announced?
So let me ask you about unaccompanied children now. You say there's an inflow of 300 to 350 unaccompanied children a day coming into the system. Your website says that you have facilities for placement of up to 14,000 children, and currently some 12,000 are placed in your facilities. Is that correct?
So as of this morning, we have 12,340 children in our care. We've got 428 available beds with another 1,414 beds subject to that could be available, but are usually, it's an issue of getting adequate staffing to be able to bring them online. We are very tight right now, Senator.
Understood. And what is the outflow of children who are actually sent to families or placed outside your facilities?
So our discharge rate has been quite high lately, actually. We've really been prioritizing and working on that. Our discharge rate on a 30-day reference has been 2.0 children per 100 children on discharge, and on the 7-day, we're actually 2.4 children per 100. I think as I've looked in the last couple of weeks, we are essentially adding almost 70 to 80 children per day just because of the inflow and outflow rates.
The net addition.
The net, exactly. Yeah.
So is it true, as we've been reading, that these children are primarily coming from 3 countries?
That's absolutely correct. We get it's Guatemala, El Salvador, and Honduras. One of the particular challenges lately has been it's a lot easier for us to place children out where they have one parent here in the United States or a close relative, because in a TVPRA we can make that a faster process to check on them. Some of the children, we've been getting an increasing mix of Guatemalan male teenagers who have no family connections here. Those become extremely difficult for us to try to place out.
I understand that part of it. It is interesting to note that these children are coming from 3 countries, not Nicaragua, not Costa Rica, not Mexico, but these 3 countries that the president now says he wants to cut off all foreign aid to these countries, believing in his mind that that is somehow going to solve the problem. I think it will make it much worse. I think it is also important to note that this administration eliminated the program where children could go through the screening in home country at the local embassy, the U.S. Embassy and Consulate. And now many of these families, in their desperation, have no other recourse to test their asylee status than come to the border of the United States and present themselves. So wouldn't you believe that it would be helpful if we had a system restored as it was under the Obama administration for screening that begins in country?
Senator, I'm not an immigration law expert. I had not known about that program in country. It actually seems consistent with the discussions that I've heard from Secretary Nielsen about the desire to have asylum claims adjudicated while people are in country. I'll be happy to raise that with her and see, because I don't know about that.
She was part of the group that eliminated it.
Okay.
And so I hope that you will raise it.
Happy to look into that.
I have a lot of really good questions on prescription drug pricing.
I hope we can keep working together, you and I, and just really appreciate your support on direct-to-consumer advertising.
Listing the price is favored by 88% of the American people. Yep. Thank you for, on a regulatory basis, for moving on this. We did include it in the appropriation bill in the last round.
We got close.
We got close. It was killed in the conference in the House, but I'm hoping and praying that Senator Blunt and others will stand behind restoring that.
I'd encourage you to take a look in the Office of Management and Budget's ROCUS system, which is where regulations are filed when sent over to OMB for review. There is a rule with a title referring to a final rule related to direct consumer advertising pending at OMB.
Thank you.
Thank you, Senator Durbin. Senator Moran.
Chairman Blunt, thank you very much. Secretary, thank you for being here. Let me raise just a topic, and then I want to continue where Senator Blunt left off in regard to transplant program. I want to highlight for you that we have 3 hospitals in Kansas, Horton, Hillsborough, and Oswego, small rural hospitals, all of them critical access hospitals. The thing they have in common, they're owned by a company called Empower HMS. Empower HMS has been investigated by CMS for billing fraud. But as a result of that and other factors, business factors, management factors, those 3 hospitals are in various conditions, either shut down or have a trustee in bankruptcy attempting to operate those hospitals. And I would, first of all, encourage you to take, not to change your enforcement procedures or not to any way pursue fraudulent behavior any less, but recognize there's a consequence to a community hospital that regardless of who the owner of the hospital is who can be gone that night, the community is left in a circumstance in which their hospital is no longer functioning. And so I would hope that CMS and others at Health and Human Services, perhaps in conjunction with our state and others, can have a plan in place that when you are creating a circumstance that forces a business out of business because of fraud, the end result is that the person who committed the fraud, the company who committed the fraud, is who pays the price, not the community who no longer has a hospital. And I would welcome any thoughts that you or your folks at CMS could provide in this particular case, but just generally there's a consequence for this bad behavior. And I hope that whatever bad behavior is determined, if you determine that if appropriate, it's referred to the Department of Justice, because the consequences for this behavior is long-term generational consequences to communities and the people who live there, just of significant challenges now as a result of, in addition to the challenges we just have in keeping hospital doors open generally in communities across Kansas. In regard to the liver allocation issue, Mr. Secretary, let me ask just a couple of questions and then express my concern and dissatisfaction. Let me first ask if you believe that enough is being done to help individuals with end-stage liver disease who are not yet on the wait list. So there's another population, those who are on a wait list waiting for a liver transplant. There are those who are not on the wait list yet. Is enough being done to advance their well-being?
I think the number one thing that we can all be doing is working, as the chairman referred to it earlier, increase the supply of livers that we have for transplantation. So that's the most important thing we could do to help with advancing individuals. I hope we're doing everything that we can with regard to care for individuals suffering from liver disease awaiting transplant. If there are things that we could be doing differently, please do let me know. I'd want to make sure we're doing that.
Would you commit the department to a full public disclosure, a transparent public debate on this organ allocation transplant process?
I'm happy to work with you on what that might look like. As I mentioned to the chairman, the challenge with this OPT and organ allocation issue is that Congress deliberately took that out of my hands to make it a non-political issue. And so when we don't like a conclusion, I'm fairly restricted in what I can do. Well, but we certainly, I believe the OPTN process was a public process with a public record, but happy to work with you and your staff on any vehicle to ensure that.
Mr. Secretary, you're moving me to my complaining aspect of by your comments, because it was only after a lawsuit was filed, as I understand it, that this allocation process was then considered for change. And when you tell me that we constructed the ground rules for you to be removed from the process, you do appoint the HRSA director. The HRSA director is one who has written a letter to OPTN encouraging them to quickly implement the decision that they made and encouraging them. I would also tell you that while from time to time in this job, people tell me something that doesn't always turn out to be true, but in our meeting, Senator Blunt and I had with the HRSA director, The request was that we make certain that our constituencies, transplant programs in our states, submit not just comments, but please bring us a proposal, because we're so interested in listening to the proposal. Don't just complain about the proposal that's out there. Tell us how to do it better. And I can tell you that the end result of our programs doing that, they were not considered. And in fact, the decision was made before those comments were submitted, before that proposal was submitted by our constituents. And I quoted you I wrote down what you said, and at last minute or late, the computer program shut down because there were so many comments. The only lateness of our programs supplying their comments and proposals was because the computer was shut down because of commentary. And the decision was made before these were ever read, and then they were approved with no changes thereafter. The original decision was made by the Liver Intestine Committee, and without ever seeing the comments of our constituents. And then secondly, it was approved immediately with no change, even though you can claim, perhaps correctly, you can claim that the comments were then read after the initial decision was made. My point is that while I'm often, perhaps I misunderstand what has been requested of me, or what my instructions are of how I can be a help to my constituents, what I think we did was exactly what we were told to do, with no beneficial thing happening as a result of following those instructions. So this process has been flawed, and it is a flaw that arises out of the fear of a lawsuit. And after a long period of time, I know what you're saying, Chairman Blunt, after a long period of time, the policy in place was changed almost overnight in response to a lawsuit. And you're right, the issue is more organ donation, and the policy that is being developed is contradictory to what you said is the goal. I'll be back for the second round.
Senator Merkley. Thank you, Senator Moran.
Thank you very much. You mentioned that there's a big influx of unaccompanied minors crossing the border. And are you referring to people crossing between ports of entry?
We will receive the 300 to 350 children from wherever they show up. If they show up at a border crossing alone, if they show up at a non-border crossing alone, their UACs, how they came across, or even if they were already resident and come into federal authorities and their unaccompanied alien children, they'll be referred to us no matter what. So I don't know where they cross the border.
So they're in Tijuana, where you're saying that youth can walk up to the port of entry and present themselves?
If a child comes up to the border, presents himself, and is a 12-year-old, a minor, say a 12-year-old, and is an unaccompanied alien children, I believe at that point, subject to whatever the rules of DHS are. I'm not DHS. We have to ask Secretary Nielsen. I believe that once they cross into the border, and if they're not immediately repatriatable, that they're sent to us. I believe that.
Okay,
I believe
so this is not the way it works, and I would encourage you to learn a lot more about this. Right now, if an unaccompanied minor comes to the border in San Diego, they are not allowed to present themselves at the border. Everyone who is 18 and up is instructed to return to Mexico to get into the book. This is the metering process. But if you're under 18, you're not allowed to get in the book, and you're not allowed to cross the border. So we are leaving these children permanently exiled in Tijuana with really no choice about how to proceed. That's a good choice. If they present themselves to the Mexican authority, DEEF, they're deported back into horrific circumstances. If they stay in Tijuana, they're subject to gangs and the sex predators that have a big sex industry there. And so their best option is to cross the border illegally. So while the President of the United States is telling the world, don't cross between ports of entry, we're blocking the minors from crossing to the ports of entry. Do you think that that's acceptable?
I do not know border law.
Well, I encourage you to find out, because you're very directly affected by it. And it's why so many minors are crossing between ports of entry rather than at ports of entry, because they're being blocked. And the fact that you haven't educated yourself about this horrific treatment of children at the hands of the U.S. government really is unacceptable. Second, you said that you have sent a letter to Congress to fund an expansion of the child prison system under this administration. What expansion level are you planning to go to?
So we sent a funding and reprogramming request that or not a request, but basically a transfer message that we were transferring $286 million using the Secretary's 15% transfer authority and then reprogramming $99 million of money that is not needed for the refugee program within ORR as part of the transfer and reprogram.
So $385 million on top of the $266 million.
And at this current rate, as I mentioned to the chairman, that will not prove adequate for this year.
So what is the capacity of the child prison system that you're seeking with this money?
So that actually is supportive of our current rates of about 14,000 beds, I believe, as well as our expected added. We're trying to add as many fixed beds as we can to care for them. You keep saying prison system. If you've got an alternative approach to how to care for these children, please tell us, because
Well, let me give that to you.
It would be nice if you told us how to do that. If there are better ways, we want to be compassionate and deliver a safe, secure environment for these children.
We'll have a little dialogue here. It's called sponsors. And the reason it's so hard to get sponsors right now is the administration is telling potential sponsors that all their information will be shared with ICE. Therefore, people are not coming forward to be sponsors because they don't want to be stuck into our criminal examination system.
I believe the Congress actually passed an appropriations rider limiting the use of any information that would go to DHS as part of the background checking that we have to do that we do as part of our sponsorship checks. So,
but unfortunately,
I think that's probably dated information.
The families are still being told that their information could be used in this capacity. So as long as you're still telling families that, then they're discouraged from coming forward.
I'll be happy to look at that to see. I wasn't aware they were being told that.
These children belong in homes and schools and parks, not locked up. I call them prisons because they are locked up. I don't know if you have visited these facilities.
I do.
But I have.
Frequently.
Okay. Well, then you understand what I'm talking about.
I completely agree with you. I do not want any child in our custody. I want every child out with an appropriate, safely vetted sponsor in the community.
Then please examine the reasons why it's so hard to recruit sponsors, because that will facilitate, and it's also costing a huge expense. This temporary influx, $750 a day for a for-profit operator to run a former air base facility, when a permanent facility costs much less. And with sponsors, it costs a fraction, just a fraction, and to have a caseworker working with those families. So not only is it much better for the children as they await an asylum process, it's much better for the American taxpayer. And maybe it means less profits for these for-profit companies you're hiring to run Homestead, but shouldn't you watch out for the taxpayers and the children instead?
Senator, I completely share your goal and my goal and the government's goal that these children should be with sponsors and not in our care.
Good.
And if we can work together to make that happen, I will be delighted to work with anyone to make that happen.
And let's just note that they're in Homestead in Florida. They have not undertaken to address the child abuse and neglect checks for the staff members so that they can make sure that the individuals they hire working with these kids do not have a record of as a sexual predator, and that's unacceptable. Thank you.
Thank you, Senator Merkley. Senator Kennedy.
Thank you, Mr. Chairman. Thank you, Mr. Secretary. Mr. Secretary, do you believe in the rule of law?
Yes, I do, especially as a trained lawyer. I do indeed.
Is it illegal to come into our country illegally?
It is indeed illegal to come into our country illegally.
Okay. Do you dislike children?
I love children, and I want to care compassionately for any child I'm ever entrusted with.
Are you trying to hurt children who are coming into our country at the border?
Not only that, but I am proud to lead an organization of people and have grantees that are some of the most compassionate, caring child welfare people that I have ever interacted with, who love these children and care deeply for these children.
I read where in March we had about 100,000 folks, mostly from Central America, mostly family units and children, come into America illegally across our southern border. Does that sound about right?
That's my information. Is it's about 100,000 coming across now in family units per month, right. And it has created an absolute crisis for my colleagues at the Department of Homeland Security.
Or double what it was, I think, 10 years ago, something like that. Yeah. Let me ask you about the Affordable Care Act. I remember when Congress passed it. we were promised, we meaning I'm an American like you are, we were promised two things. We were promised, number one, that it would make health insurance cheaper, more affordable. Has it done that?
No, it has not. It has actually, we were promised that health insurance would cost half what it cost at the time. In fact, during President Obama's tenure, it doubled in cost for people having to buy insurance.
I remember vividly, because I watched it on C-SPAN, I remember Congress also promised us that it would make health insurance more accessible. Has it done that?
No, it's not. In fact, it's restricted choices for individuals now, with a large percent of states having only one carrier in the individual market.
All right, now, let me answer this. The President has expressed his disappointment with the Affordable Care Act. Does he support getting rid of it before we have a replacement?
The President has always supported replacing the Affordable Care Act with something else that is better.
Okay,
Never that there should be nothing.
I want to be sure I understand, because there's been some innuendo here.
Right.
Does he support getting rid of the Affordable Care Act without a better plan in place?
Absolutely not. He insists there be a better plan in place for people.
Do you know of anyone on Capitol Hill, Republican or Democrat, who supports a health care insurance program or a health care delivery system that would not cover pre-existing conditions?
I haven't met them.
Okay. Does the President support a replacement plan for Obamacare that would cover pre-existing conditions?
He does indeed, and he will never sign any other plan that doesn't take care of people with pre-existing conditions.
Okay. Let me look at, I want to look at the health care system from 30,000 feet for a second. Here's what I don't understand. I keep reading that 10% of the American people spend about 67% of the health care dollars, which makes sense because we all know that the chronically ill spend more money than others. And when you run the numbers, when you consider that we've got 320 million people, really 330 million people, so 10% of that is 33 million people, and we've got a $21 trillion, that's 12 zeros, GDP, and we spend 18% of that on GDP, and you take 2/3 of that 18%, and then you divide it by 33 million, what you come out with is $80,000 a person. So for these 33 million people out of 333 million, we're spending about $80,000 a person. Why can't we identify those 33 million? I didn't say 8,000, 80,000. I'm going to land this plane on time, Mr. Chairman. Why can't we identify those people and with $80,000 a person manage their care better?
You know what, Senator, you're absolutely right. We in fact, we can, and we can do that through vehicles like either invisible or visible reinsurance pools. For instance, even under the ACA, I have approved 7 state reinsurance plans that have brought premiums down in those states by anywhere from 9% to 30% by cleaving off the risk for those higher risk people and separately reinsuring that so that the burden isn't borne by all the other healthier people in that pool. Absolutely.
Thank you, Mr.
Thank you, Senator. Senator Schatz.
Thank you, Mr. Chairman. Ranking Member, Secretary, thank you for being here. I'm worried about tobacco use among our young people, and that's why I'm about to introduce the Tobacco to 21 Act with Senator Young. Our bill would raise the minimum age from 18 to 21 for the purchase of tobacco products, and that includes the sale of combustible cigarettes and e-cigarettes. The Institute of Medicine has found that raising the tobacco age of sale to 21 would reduce tobacco initiation, especially among kids 15 to 17. It would also lead to a 12% decrease in smoking prevalence. 9 states, including Hawaii, and hundreds of localities have already taken this action. Do you agree that tobacco use among youth is a severe public health problem? And do you commit to me that we can work together on this legislation?
Well, Senator, thank you very much for that question, and thank you for your work in this area. Like you, I am extremely concerned about tobacco use, and specifically the e-cigarette epidemic among our youth. I'm committed to working with you and with other members of Congress on legislation to address tobacco use among youth, as well as taking any necessary regulatory action. Commissioner Gottlieb, his last day today, and I have been very clear that while e-cigarettes may offer a lower risk alternative for adult smokers who still want access to nicotine, we cannot allow e-cigarettes to be an on-ramp to combustible cigarette use or nicotine addiction for an entire new generation. FDA is proposing to prioritize enforcement of flavored e-cigarettes that are offered for sale in ways that pose a greater risk for minors to access the products. For instance, FDA will consider whether the products are sold under circumstances without heightened age verification. And while we pursue changes to regulatory policy, we call on the industry, manufacturers and retailers to step up with meaningful measures to reduce the access and appeal of e-cigarettes to young people. The epidemic-level rise in youth e-cigarette use has also prompted a series of escalating actions by the FDA in both enforcement and public education. So thank you very much, sir, for your help, and I look forward to working with you on this.
Thank you. Let's move to telehealth. I know you are a big supporter of telehealth and that you've noted that the regulatory and payment barriers can limit telehealth services. One section of the Connect for Health Act would give you the authority to waive barriers to traditional Medicare reimbursement under two circumstances: if the telehealth services would reduce spending while maintaining quality, or if the telehealth services would improve healthcare quality without increasing spending. Can you talk about what that waiver authority would mean in terms of public health and especially expenditures regarding public health?
So as you mentioned, I've been passionate in my advocacy of telehealth. I think it's vitally important for states like Hawaii, for states that are rural, for expanding access to care, and also for expanding just the quality of care, even where we have care delivery, and to make sure that all of America shares in centers of excellence through telehealth. The Social Security Act, unfortunately, was written in the 1960s before telehealth existed. And so there are many barriers to that, and I look forward to working with you on any ways in which greater flexibility could appropriately be provided to me, especially in ways that don't open the door to fraud, abuse, or, of course, waste of precious taxpayer beneficiary resources.
This remains we got a lot done with Senator Hatch's leadership and with a big bipartisan group on telehealth. There are a few more things to do. This isn't the only one, but the waiver authority is sort of the holy grail. So for the members, we really got to get this done.
I hope perhaps this could be included in the work that Senator Murray and Senator Alexander are leading on cost work.
Yeah, and then just a final comment and question. I was struck by the exchange between Senator Merkley and you in one particular way. Obviously, it got contentious because this is, frankly, the kind of thing that should cause people to be emotional. But to the extent that there's a statute that provides for confidentiality for potential sponsors, but in the moment where a decision is being made, sponsors are not aware of that statute. That seems to me to be a light bulb going off for all of us, that we need to do a better job of communicating to sponsors that their confidentiality is protected, that their family situation is protected, and that we in fact, as a matter of government policy, whatever we think about the border wall, whatever we think about whose fault is what, and what we ought to do with consular offices and all these other arguments, that at a minimum, these kids need sponsors, and to the extent that potential sponsors are afraid to do so, because they're afraid they're going to end up in some database, we need to do a better job of telling them that there is a law that protects their confidentiality, and I'm hoping we can work together to follow up on that.
Thank you, of course.
Thank you very much.
Thank you, Senator Schatz. Senator Hyde-Smith.
Thank you, Mr. Chairman, and I certainly appreciate Secretary Azar being here today and answering the questions the way that you're doing this. I obviously the senator from Mississippi, and we have so many rural hospitals in Mississippi that are really struggling. A recent report found that half of all rural hospitals in Mississippi are at high financial risk of closing. I just read an article that Mississippi has more rural hospitals at risk of closing than any other state in this country. When a hospital closes, obviously, that the whole community is affected in so many ways. And, not only the employment there, but mainly, and what's most important, it means no more access to emergency care for the community's residents. In an emergency, timely care is of essence. And having close by access to them can truly mean life or death We just recently had a young lady in Mississippi just a few weeks ago that died of an asthma attack. So I guess my question is, what is HHS doing to respond to these rural hospital closures that is very critical in my state?
Well, thank you. You have repeatedly raised with me the concerns about rural hospital access in Mississippi, and in part because of your efforts, I have created a task force across HHS to help come up with all ideas that we can around how we can help address the hospital crisis. Let me give you some ideas. One of them we just were discussing, which is telehealth. How can we help make sure that we're expanding access into rural America? Because we'll end up consolidating everyone living in urban areas if we can't provide them health care in rural America. So telehealth is important. We have to make sure that providers are able to practice to the maximum of their licensure so that we're not having artificial restraints on trade and competition that are blocking access in rural America. And we also have to make sure that our regulations at CMS or otherwise are not creating artificial barriers to economically viable models of hospitals in rural America. Are we trying to force a 1960s model of hospitals through our payment systems and other regulations onto rural America? So we're looking at how do we even reconceive the needs of rural America from a hospital perspective. You said ER, for instance. I was talking with the leader of a critical access hospital yesterday. I learned about a requirement that we have, which is that to be a CAW, you have to have a surgeon on staff who might do 20 surgeries a year. One has to ask, does that requirement still hold in the modern era, and is that part of making that facility economically viable long term to be able to provide access in that community? So this is a deep passion of mine. We're working on this. Any ideas you have of things we can do to be helpful, certainly we want to be there.
Thank you very much.
Thank you, Senator. Senator Baldwin.
Thank you, Mr. Chairman. Secretary Azar, I want to tell you about Zoe from Seymour, Wisconsin. Zoe was born with a congenital heart defect, and she had actually open heart surgery at 5 days old. She will be able to continue to get coverage and the care that she needs thanks to the Affordable Care Act and its protections for people with pre-existing health conditions. When the Republicans were working to repeal the Affordable Care Act legislatively, I got a letter from Zoe's mom, Chelsea. And Chelsea wrote to me and she said, to me, it's like they're taking the American dream from her, referring to her daughter, Zoe. She wrote, I'm pleading with you as a mother to fight for those with pre-existing conditions. Kids in Wisconsin with pre-existing conditions are counting on you to protect that right. The administration, your administration, recently decided to support a lawsuit aimed at striking down the Affordable Care Act in its entirety and all of its protections. So how do I explain a decision like that to Zoe and her mom? Zoe, by the way, just celebrated her 6th birthday. And this is more or less a rhetorical question because I have some specifics. But how do you tell a little girl like that what's going to happen to her? And so I want to just confirm my understanding that if the Affordable Care Act is struck down in its entirety in court, a position your administration is supporting, what protections preventing insurance companies from discriminating against those with pre-existing conditions will still remain in law if it's struck down?
Yep. So, of course, there are the existing ERISA protections and HIPAA protections around pre-existing conditions that wouldn't be impacted by that for those of us who have
the marketplace
employer-sponsored insurance. And then, as I was mentioning with Ranking Member Murray, we will be working then with Congress to ensure that any new better care has protection for
pre-existing conditions. So in other words,
conditions. If
it's struck down for a time, there will be nothing in place to protect Zoe and kids like her. The truth is that there isn't a plan right now to protect Zoe or people like her with pre-existing conditions. And not only would this lawsuit take away these protections, but President Trump has broken his promise by expanding the use of junk health plans. That's what I call them because they don't have to cover pre-existing conditions. And I just want to share a couple of examples in Wisconsin. One of the plans currently available in Wisconsin from Companion Life, the very first sentence of their policy states, quote, pre-existing conditions diagnosed within the 60-month period immediately preceding such covered person's effective date are excluded for the first 12 months of coverage. Another plan sold in Wisconsin now says, quote, no benefits are payable for expenses for a pre-existing condition, described as a condition that, quote, would have caused an ordinarily prudent person to seek medical advice, diagnosis, care, or treatment within 12 months immediately preceding the date of coverage. So explain to me how this decision, not only to join this lawsuit to try to totally repeal and overturn the Affordable Care Act, but this decision to proactively expand the use and availability of these junk plans is not a broken promise to protect people with pre-existing conditions.
So I assume you're referring to the short-term limited duration plans, which we restored to use as the Obama administration had. These plans are not for everyone, and if a plan like that, and I'm quite glad that the enhanced consumer disclosures that we have are making it so apparent that if you had a pre-existing condition, those would not be plans that you should choose. You would very well want to be getting an exchange-based plan that would cover your pre-existing conditions, or a short-term duration plan that does cover pre-existing
conditions. Well, but you're arguing in court
conditions.
to overturn the Affordable Care Act, so there won't be a marketplace. Now I want to move on to something that you and I have discussed at length, which is drug prices. If the administration is successful in the lawsuit and the Affordable Care Act is struck down, the law's prescription drug price reforms would also be gone. Secretary Azar, your own Medicare prescription drug price proposal would be wiped out. And that's because your own pilot program is being tested through the Center for Medicare and Medicaid Innovation, CMMI, which was created under the Affordable Care Act. So yes or no, Mr. Secretary, if the lawsuit succeeds and the Affordable Care Act is struck down in court, CMMI will cease to exist, and so will this pilot. Is that true or false?
There are a great deal of ifs in there, but CMMI is part of the Affordable Care Act, and my hope would be that any better care system we set up would similarly give me authorities to do demonstrations and pilots such as the one that we are firmly committed to there of international pricing index.
So it would cease to exist?
We would have to find additional authority.
Thank you, Senator. Senator Capito.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. My first question from the state of West Virginia, Senator Manchin, we're both lucky enough to be on this subcommittee, have been ravaged by the opioid epidemic, but we're starting to look at some of the ripple effects. And I know that you, in your statement, addressed the increase of Hep C and B, and also HIV. Could you just tell me just briefly how you're meeting those challenges, working with our public health officials in our state? Some of them, I think, have been very forward-leaning in trying to master this.
Yeah, absolutely. So first off, the ending HIV epidemic will be very helpful with the additional funding and the focused efforts there. We see 10% of new HIV cases are coming out of injectable drug use.
Right.
And so the efforts there where we hope we will actually completely stop the spread of HIV in this country would tackle that. In addition, we have special funding as part of the budget and the opioid initiative that we've requested to help with HIV spread and Hep C infectious disease spread connected to the opioid problem that we have in the country.
Well, in my conversations with the head of the CDC just recently, he did tell me that with the new availability of different metrics that you're able to identify clusters quicker and be more effective with that. So that's very important to us. I'm going to shift to another issue that I'm very passionate about, and that is Senator Reid and I, he's a member of the subcommittee as well, worked together to pass the STAR Act, which is the Childhood Cancer Survivorship Treatment, Access, and Research. We got $30 million in the budget for that. I'd like to know what your department is doing on that and where you think it will lead to.
Yeah, well, first, thank you for your support of the STAR Act and getting that passed. We've already begun implementation at the National Cancer Institute of the NCI-specific sections there. One of the most important parts here is enhancing the biospecimen collection and biorepositories to really aid us in the research programs needed to focus on pediatric cancer. That's vital to just building the evidence base and information we need, and also to continue to conduct and support childhood cancer survivorship research efforts. At CDC, we're working to implement the CDC cancer registries there. So we look forward to their continued successful early case capture program that lets us identify children right away. So that also helps us with the research programs by getting that type of information and making that available.
So does the budget reflect next year a continuation of that funding?
So as you know, our budget proposes an additional $50 million to NIH for the Pediatric Cancer Research Program as part of a $500 million 10-year program with a focus on pediatric cancer research.
Good.
Pediatric cancer has been neglected for a long time.
I knew that, yeah.
And thanks to the STAR Act, thanks to the President's initiative here on pediatric cancer, I hope we'll get a greater focus there.
I hope so, too. And some of our leading hospitals, research hospitals in our state are putting a great focus on this. Lastly, I'd like to ask you another thing, that a statistic that I found rather surprising, because I don't think we think of ourselves like this as a country, but the rising statistics of maternal mortality. And I think you're quoted in your statement as saying over 700 women died in and around associated with childbirth. We did pass with a bipartisan effort, a maternal Mortality Accountability Act, for us to get good statistics on what's actually going on here, because you state that these deaths are actually, many of them, very preventable. What steps is your department taking to take charge of this issue?
Well, as you mentioned, maternal mortality rates in the U.S. have more than doubled over the past few decades.
I mean, do you have any idea why, or is that?
Well, so much of it is about prenatal care and labor and delivery care and access. In rural America, we have a real labor and delivery crisis.
Well, yeah.
And associated with that is appropriate prenatal care. And of course, the immigration crisis is bringing in so many individuals in terms of getting adequate prenatal and labor and delivery care also. I don't know the full demographic breakdown on that, but I appreciate, obviously, Senator Murray's leadership in this space also. And our budget proposes the $58 million for the maternal mortality prevention and surveillance at CDC,
right.
which you just mentioned, and that includes $12 million to support data collection and research to understand even better the causes of these deaths, because so we really can aim at the problem and then tailor solutions towards that.
Well, I think you'll find both Senator Murray's leadership and others. You'll have a very supportive Senate and probably Congress in this efforts. Obviously, the President's supporting this as well.
Absolutely.
Thank you so much.
Thank you.
Thank you, Senator Capito. Senator Murphy.
Thank you very much, Mr. Chairman. Thank you, Mr. Secretary, for being here today. I want to thank the chairman and the ranking member for acknowledging at the outset what is the reality here. This budget is not going to be reflected in the one that Congress ultimately passes. We would never support the kind of draconian cuts that are in it to people in need, to very sick people, to very vulnerable populations. And so I understand that we are going to work together, Republicans and Democrats, to make sure that this budget never, ever sees the light of day. But I think for the good of the order, it makes sense to repeat why this budget is so offensive to many of us. It's not just the cuts, it's that they stand in contrast to a giant gift-wrap present that this Congress gave to the very, very wealthy in this country about a year ago, a $2 trillion unpaid-for tax cut that was promised to increase wages by $4,000 per person. That simply has not done that. It, when fully implemented, will deliver 80% of the benefits to the top 1% of income earners, and now we are seeing who's being asked to pay for it. Frail seniors in Connecticut who are going to have their heating shut off in the winter because the Trump budget doesn't fund the low-income heating assistance program. So I think that's at the heart of our frustration. It's not just that this budget doesn't reflect our values, is that it stands in contrast with a tax cut that just is not going to deliver results for the majority of Americans. Mr. Secretary, I wanted to talk to you about the effect of this budget on the opioid epidemic. In your testimony, you point to about $5 billion in funding that is directly dedicated to the opioid epidemic. That is largely money that was already in the budget. But it stands in contrast to $1.5 trillion in Medicaid cuts in this budget, including the wholesale elimination of the Medicaid expansion. 4 out of 10 non-elderly adults that are dealing with opioid addiction today are on Medicaid. And so when you put $5 billion in essentially flat funding for specific opioid treatment next to $1.5 trillion in cuts to the insurance program that actually allows states to pay for treatment, the result is a devastating net negative, a dramatic contraction of federal dollars out of the opioid treatment system. And I guess I just want to be honest what we're doing here. I know you may say, well, we're still going to spend more money in real dollars, but this is a $1.5 trillion cut compared to what we expected states to spend. And I feel like we should just be honest that what this budget asks is for states to pick up a much bigger share of the burden for caring for people with addiction. And that this national emergency we declared comes with it an expectation that the federal government will do less and states will do more. Connecticut will try to scramble to come up with the money when we lose 100,000 people off of the rolls of our Medicaid program. Other states may not be able to come up with those dollars. So I just want asked you that. Isn't this what we're doing? Aren't we just asking states to essentially pick up the burden of the opioid epidemic, given the comparison of the Medicaid cuts in this bill to the $5 billion in specific opioid funding?
I don't think so. Well, you're right. We have a $1.5 trillion reduction that's in the budget for the Medicaid expansion and the Affordable Care Act exchange subsidies. We add back a $1.2 trillion program that would be state-based flexibility. My hope is that it would actually correct. One of the things I worry about with the opioid crisis and many other public health issues we deal with is that the Medicaid expansion, with its focus on able-bodied adults, has taken us away from it's actually incentivized coverage there away from the aged, disabled children, pregnant mothers, those, for instance, opioid addicted, that are part of the core Medicaid. And my hope is that with the $1.2 trillion program and the complete flexibility for the states on that money, that they actually would focus that in areas like you just talked about, where the needs are greatest, and really prioritize in those areas. And it might actually enhance coverage and access for those individuals that we all care so much about.
Yeah, we've heard this for a long time, that flexibility will allow states to enhance and greater focus their coverage. But in the end, it's a whole lot less money than they were getting today. And states are begging for additional dollars to care for people with opioid epidemic, asking them to just focus better with less money. I just think ignores the feedback that all of us are getting, Republicans and Democrats, about the realities on the ground. Thank you, Mr. Chairman.
Thank you, Senator. Senator Manchin, followed by Senator Shaheen. Senator Manchin.
Thank you, Mr. Chairman. I appreciate it. And thank you, Secretary, first of all, for being here and also for your service. You and I have talked briefly, and I'm asking for the help that we need in our little state of West Virginia. We face the largest per capita economic burden in the country, and I think my dear friend, Senator Shaheen, is right behind us on this. The epidemic of opiates is costing our economy in our little state $8.8 billion a year, and forcing us to dedicate the largest share of our GDP of any state to costs related to the crisis, which is 12%. I appreciate what you all have done, and everybody's concerned about the cutting. I think we'll work through this, okay? But the 15% set aside that you have for hard-hit states, I'm asking through your rules and regulations if you can do this. You have to take in consideration the deaths per capita, not just the total deaths. I got counties that it's enormous, but But if you look at the total deaths and offsetting the 15%, we can't help them that much. Does that make sense?
There's a lot of sense to that. And I appreciate you raising that issue. One thing would be where, and you all helped us a lot with the support act, with not just the support act, but with your appropriations funding on opioids, with helping us with the formulas to allow a focus of money on the highest burden states. If that issue of deaths versus incidents per capita is in there, obviously I'd need you to fix that.
We can, if not, if you
and then there may be some allocation issues within the state. For instance, rural versus urban within the state. Happy to work with you and the government in West Virginia to educate and focus on that area.
I have two really quick ones in my final comment. The Jesse's Law, we talked about that. And you might want to expand on what can be done and how quickly you can make this happen. I know there's some hoops that we have to draw through, but all of us have agreed that Jesse's Law is something that's extremely needed, and it can save lives. And it's so simple, but yet we're running into so many complications as far as privacy, HIPAA, and all these other things. Can you just briefly state that?
Absolutely. Thank you for prioritizing the work in this area. And I am going to be speaking with our head of the Office of National Coordinator as well as SAMHSA to make sure it's a priority to share these best practices that are part of the Jesse's Law that are in the Support Act. We do have to examine issues like 42 CFR Part 2 to make sure that there aren't unintended consequences, for instance, where providers don't put information about somebody's addiction status in the electronic medical record for fear of additional regulatory complications there. And so we need to work on that and make sure that's not standing in the way of appropriate care and treatment, because what happened to Jesse shouldn't happen.
Absolutely. And I appreciate you understand it, and I appreciate your diligence towards that, because it just means so much to all of us. And very quickly, funding for this horrible, horrible disease of addiction. I've introduced Lifeboat year after year after year. Lifeboat basically says is that all pharmaceuticals that are producing opiates should pay 1 penny per milligram for production fees. That would give us a permanent funding. I know that's it's a tough one. It's a heavy lift for some of my friends. That's not I'm not looking at that as a tax. If you want to make this product, if you think we need all these products, then you ought to pay a production fee, and let us make sure that we have a constant stream of money that goes to the areas that are hit the hardest.
You know, the genesis.
It won't put anybody out of business, will it?
Well, the genesis of this crisis were the legal opioids, and that's why I am so glad that we have gotten legal opioid prescribing down by 20%, and I think the MME, the morphine molecule.
You can talk to the president on this. This would be a great Lifeboat Act. This is 1 penny per milligram would be a tremendous help. Finally, on Affordable Care Act, the president said he's not going to do anything until after 2020. So we're going to have it, depending on what the courts do. Let's say the courts kind of abdicate from this and we still have it. You have a lot of expertise and you bring an awful lot to the table. How would you fix what you have in front of you if that's all you had? Nothing new, not reinventing the wheel. Yep. I wasn't here in 2009. I'd been hard-pressed to vote for what was in front of me. I would have worked like heck to change a few things. But what we have is integrated into our system, 1/6 of our economy. How would you recommend the fixing?
I believe there are tremendous deep problems in the ACA and just how the insurance benefit is structured there. Issues around I'll give you one example, which is the 3-to-1 rating. Essentially, you've made insurance for individuals who are healthy and young, say, unaffordable, and they walked from the market. And that created this kind of downward spiral that we've seen.
You're saying because we're preventing higher than a 3-to-1 rate on people that are very sick.
Right.
But that's where we get into it, where our differences with our Republican friends. Yep. They cannot come up with how do you protect pre-existing conditions. You can say, oh yeah, we're going to make it illegal for anyone, any insurance company not to sell. And that by definition, you said they can't deny you pre-existing condition. You can charge us out of the market. I can't afford it, or my aunt can't afford it, and it'll break the family. And they go without, because back home in West Virginia, they'll say, I don't want to be a burden to my family. That means they can't afford what's out there. You're preventing them from being denied. You're not preventing from being able to afford it.
Right. There are ways that one can actually make sure that insurance for people with pre-existing conditions is affordable. Senator Kennedy and I had a bit of a discussion earlier about reinsurance vehicles that are very, very actually quite well established and work very well.
Well, here's
I've been
what, we
using
have a
them
bill. We
to
have a
help
bill.
the-
We have a bill called. It was the Collins-Nelson, and I'm going to be introducing that with Susan now, since Bill's not here. And we would love to have your support on that, because we think that would be a big fix, and reducing from the private pay could reduce anywhere from 20 to 40% overnight.
But we'd be happy to work with you on that, especially if we could do that in conjunction, as we had before, with what was going to be the Alexander Murray Collins-Nelson package that would have CSR funding attached to that.
Those two bills have been laying on Majority Leader McConnell's desk for close to 2 years.
But we'd be happy to work with you on those. Of course, I think where we got a stumbling block, Senator Murray, was around ensuring that the funding on the CSRs would have appropriate HIDE Act protections, and that ended up, I think, being the stumbling block for us at the end of the day.
I'm sure she would like to talk
Thank you,
about
Senator.
that, but thank you,
If
Senator.
you want to stay for a minute, there'll be a time for more questions if you have more to ask. Senator Shaheen.
Well, thank you, Mr. Secretary, for being here. I would say that there was actually an agreement between both sides on the Alexander Murray legislation and a strong list of bipartisan sponsors. And it's unfortunate that because there was opposition from the White House, because there was opposition from the leadership in the Senate, that bill wasn't able to come to the floor. And I would encourage you, I think everybody who has been in the Senate since we passed the Affordable Care Act recognizes that we need to improve some things, that some things are not working. But the response is not to refuse to come to the table. It's not to overturn the law so that people have no alternatives. The answer is to work together to get it done. And I'm very disappointed that we have not seen that kind of leadership either from the Senate leadership or from the White House. So I hope you will share your views that you think there are things we could do together, because so far that's been missing from the conversation. I want to just agree with Senator Manchin of the importance of the set-aside on the opioid funding. It has been critical in a state like New Hampshire where, as you know, because you're familiar with it, we have a huge problem. We are behind West Virginia in terms of the overdose death rate, but way too high for our state. We have way too many families who are affected, and the pain is, you can't talk to anybody in New Hampshire who doesn't know someone or hasn't been affected personally by this epidemic. And those set-aside dollars that have been used for the state opioid response grants have made a huge difference in New Hampshire. It's allowed us to set up a hub-and-spoke system that keeps people within an hour from a place where they can get treatment, which has been very important. We're still waiting to see exactly how this is going to work, but it's an improvement and something that would not have been done without those dollars. We had a hearing here a couple of weeks ago, and I was talking to you about it at the start of this hearing, where there were people from states across this country who were directors of programs to respond to the opioid epidemic. And I asked them all a question. One was from New Hampshire. She heads a recovery center. I said, what happens if these federal dollars go away? And she said, well, I'll go back to bake sales. Some of the other folks were a lot more direct. They said, people will die. And in New Hampshire, the expansion of Medicaid has been one of the things that has been most critical to ensuring that people can get treatment and that we can prevent some of those deaths. And yet, I share the concerns that Senator Murphy was raising about what this budget does to repeal the Medicaid expansion and replace it with block grants, because not only does it cut the amount available to states, but it assumes then every state is going to come up with the funding to replace that. And I think that's a huge question in a lot of the country. So can you talk about what we should say to those people who are running the programs to address the opioid epidemic, about what they should do if these federal dollars go away?
Well, I appreciate your concern. The president is adamant, our budget reflects this, about the funding and support for the opioid epidemic and the work that we have together, and want to keep working with you to ensure the states that have the highest burden are getting the share of resources that they need to deal with this. In addition, our budget proposes with Medicaid that we would actually expand access for women postpartum for 1 year. To have eligibility postpartum who are suffering from addictions. That's one of the changes we've got in the budget. We continue to process the IMD exclusion waivers to ensure that we have inpatient capacity and expanded capacity for inpatient in communities. So we're continuing to drive forward fully engaged, fully focused around the opioid epidemic. We're seeing the results. We targeted the state opioid response grants actually to ensure access to medication-assisted treatment, you know, the gold standard. And I think we're helping to really just expand capacity by making it quite clear that this is the most evidence-based approach to people for treatment and lifelong recovery.
Well, I appreciate those changes. I think they're very important. But if the fundamental funding source and coverage source for people to get treatment goes away, then those will make a small difference, but they won't address the underlying problem. Can I ask one more question, Mr. Chairman? Yesterday, a study from the Kaiser Family Foundation found that Medicare Part D spending on insulin grew by 840% between 2007 and 2017. As you know, diabetes is one of the most expensive chronic illnesses we have in this country, and figuring out how to help patients with the cost of insulin at the pharmacy counter is very critical, but it's also a question about how can we be most effective with our public dollars to address illness. So I know that your department has proposed new rules to limit the impact of pharmacy benefit manager rebates that have helped to drive up the cost of Part D drugs. Can you tell us whether you think removing that link is going to help address things like those insulin costs, or do we need to be doing something else?
Well, I would defer on the something else side, but I can tell you that the rule that we have proposed to get these rebates out of the system and instead have those go as discounts to the patient at the pharmacy level would be revolutionary for the patients in the situation you're talking about, especially classes like insulins or arthritis medicines or high-cost cholesterol medicines that are very highly rebated now. You might have in some of those classes average 70% rebates. Imagine January 1 of 2020, when that patient walks in the pharmacy, if this rule goes forward, they will get a 70% discount every time they fill that prescription. It's a revolutionary change for patient access and affordability if we can get this through. And I pray that we'll have your support to help do that. It's $29 billion of rebates that are going to PBM, the pharmacy benefit managers now, that would go to patients starting January 1, 2020, if we can make this happen.
Well, I look forward to hearing more about it.
Thank you.
Senator Murray.
Thank you very much, Mr. Chairman, and thank you for allowing us to ask one more question. Mr. Secretary, I did want to express my serious concerns about what's going on in the unaccompanied children program. Most shelters, as you know, are working to provide excellent care to this very vulnerable population. HHS, as you know, is charged with the welfare of every child in its care, and I am deeply troubled by some of the reports of forced drugging, sexual abuse, substandard conditions at some of the temporary facilities. And I was especially appalled by the great lengths that former OOR Director Scott Lloyd went to prevent minors in ORR custody from accessing reproductive care, including cases where pregnancies were the result of sexual assault. And despite the fact that a federal judge issued an injunction in March of 2018 barring ORR from obstructing access to abortion, a recently released spreadsheet shows that ORR continued to track minors' private reproductive health information through June 2018. And there's no indication that the information collected in that spreadsheet is being used to ensure access to reproductive care. I wanted to ask you, does ORR still keep a spreadsheet containing the reproductive health information of pregnant minors?
I'm not aware of any centralized spreadsheet. I believe, I could not answer for him, but I believe the intention, this was the last menstrual period date, which of course for any of us who've had children know is vital to prenatal care, just to know gestational age of the child, not ongoing cycle information or otherwise than that is my understanding. I'm not aware, though, whether there would be, and I doubt there's any type of central repository. We've actually ensured now the delegation from the ORR director of all decisions on significant medical procedures for our unaccompanied alien children to the ORR career staff. And I believe we're fully compliant with the court's order and injunction and faithfully executing on that.
Well, what are you doing to make sure that ORR complies with the court order?
I have and always will make clear that when there's a court order in place, we are to faithfully apply that. And so the order that you're referring to, I believe that we are in full compliance with it. If we're not, I'd like to know. But I certainly would give instruction always that we should be in compliance with court orders.
Okay, well, when were you first aware that Director Lloyd was being regularly briefed on pregnant minors' health information and actually was personally contacting pregnant minors to discourage them from seeking abortions? Do you believe that's an appropriate role for the director, and when did you know?
I think you and I spoke about this actually during the confirmation process, if I remember correctly, back in my first hearing in early December before I was in office. So I think probably this was an issue of some controversy even then, public controversy. So I think probably around that, goodness, I can't quite remember. Listen, the issue of a 12-year-old girl who is pregnant in our care, we're the custodian of that child, and we are delegated to make the serious medical decisions as the parent of that child, but in consultation, if we can, with the parents of that child.
This is really important information, and Senator Feinstein and I sent last week a letter to you asking you to have your staff brief us fully on what you are doing, where that information is, and how it's being used, and would like you to commit to having that.
We'll certainly work with you on that, absolutely.
Thank you.
Thank you, Senator. I have two quick things. There'll be more for the record, I'm sure, but one is we're nearing the end of the 2-year pilot period of excellence in mental health. Not my goal or Senator Stabinov's goal, I don't believe, for the federal government to be the permanent sponsor of that effort of treating behavioral health like all other health, but it is our goal to come up with all the information we can about the impact of treating behavioral health like all other health and what's the impact on other health costs. So my request to you as we talk about maybe a 2-year extension to just get more information for states to look at in the future, be very helpful if you could commit to provide us any early CMS data before that program expires.
I'll work with the administrator to get you any information we have, data to help support the analysis of your to support that legislative effort.
If you understand what I'm saying, if you've got early data,
any data,
exactly, to show one thing or another here, it would be helpful for us to say, we believe this is where this is headed, and we'd like to compile a little more information. And the goal here, again, is not for the federal government to make behavioral health their health responsibility, but put the information out there that shows not only is this the right thing to do, which everybody already knows, but it's the fiscally smart thing to do as well. And my other question on the sponsor criteria on the unaccompanied children that you talked about, who sets that sponsor criteria in terms of what the sponsor has to provide and how that is shared or not shared? Is that you, or is that Homeland Security?
So it would be statute as well as us. So the sponsorship criteria are set in I believe it's the Trafficking Victims Protection Act, largely the categories of Category 1, 2, 3, and 4 sponsors. Our preference is always a Category 1 sponsor, which would be a parent or guardian here in the United States already that we can place them with. Then category 2 would be our other relatives, aunts, uncles, brothers, sisters, that we would place them with. And then 3 would be more distant relatives that we could place. What we do is a titrated, there are certain mandates in the statute, for instance, where there are various red flags. We have to do home visits and home inspections. We always have the right to and do fingerprints and other biometric checking to confirm identity or to assist with background checking of any individuals. That, to my knowledge, has long been the case. We have had some heightened requirements, in part driven by, if you'll remember, your colleague on the Permanent Subcommittee on Investigations did some work, Senator Portman and Senator Carper, on children who got placed with traffickers or ended up with traffickers in Ohio at the egg plant. And so it's always a balance. We want to make sure we're balancing keeping children in congregate care as short a time as possible, but also making sure when they're placed out, we're placing them into a safe environment. And so we're always assessing any discretionary aspects of that balance to strike that. So we have required fingerprints at various times of all, say, household members for a level 2 sponsor. We decided in December that we weren't seeing enough hits there in terms of information, added information, that was automatic, that merited the delay from people coming in as unrelated as these household members. And so we pulled back on that. We're always assessing what the needs are.
I believe in your earlier response to Senator Merkley, you said you believed your direction from the Congress was that information is not to be shared with the Immigration Service.
No, I want to, if I could clarify. That information is shared with immigration so that we can confirm identity, do background checking, and also get immigration status. We have long, previous administrations included, gotten immigration status. That's part of our placement decisions. Not that they're precluded by being illegally in the country. We don't do that. But rather, if somebody, for instance, is just about to be deported, they wouldn't be an adequate long-term sponsor for someone. So we want to make sure of that information. My understanding was
if you find out someone's illegally in the country and not about to be deported, what do you do with that?
We still place if the person is within the categorization of sponsors and an appropriate sponsor from a child welfare perspective, we place the child. Most of our children are placed probably with individuals who are illegally in the country. That information at DHS, my understanding is that there is an appropriations rider that was passed as part of the large budget deal to end the closure of the government that actually restricts the use of that information over at DHS. But I'd have to defer to DHS and its lawyers on that question.
Thank you, Secretary. Senator Moran.
I'll attempt to be brief, Mr. Chairman. Thank you for the second round. Mr. Secretary, I want to highlight, you and I would agree this is a significant issue affecting liver transplants. This policy has consequences and it's significant. That's true, correct?
Yes, the issue of liver transplants are very important to all of us, absolutely.
And I got involved or interested in this topic after a conversation with liver transplant program in my state. But as a result of that activity, I've been amazed at the number of people, individuals in Kansas and elsewhere, who come to me to talk about the importance of this liver transplant policy. People who have had a liver transplant, people who are waiting for a liver transplant, people who want to be on a list for a liver transplant. And again, you and I both would highlight and use this opportunity to highlight the importance of people being organ donors. We need more organs to meet the demands. But this is not just about the consequences to a particular transplant program. This issue has significant consequences, in fact, life and death consequences for people across the country. And finally, I would remind you that Senator Grassley, along with almost half the Senate, sent a letter to you, which I don't believe, at least I've not seen a response, and I would encourage you to respond.
Okay. Thank you. And I do want you to know that I take that letter very seriously. It has my personal attention, and that was what prompted me to actually ensure that we went to OPTN and asked them to think again and to ensure the full consideration of the comments out of Kansas and Missouri providers. That was, even in spite of the computer glitch, and I understand the process here was bad, okay, in terms of the interactions with you. And on behalf of the department, I apologize to you for any lack of courtesy and also just any problems in that process. My understanding is those comments, in spite of the computer glitch, were summarized to the OPTN board in their decision making. So at least it was part of the summaries as part of the original decision making, and then presented in full to the Liver Committee later. I understand that is not necessarily everything you want to hear in terms of it would have been nice if they had been presented in full before any initial presumptive decision was made. That's why I went back and said, please think again. Please, look at these comments, look at these concerns. Obviously, I've got tremendous respect for every signatory on that letter. I can only, and I hope if you don't have it, we'll get it to you, the letter of response that I got. And if there are further avenues that are appropriate, legally justifiable to ensure appropriate process and consideration, I'm most happy to consider them.
I have not been discourteously treated, but I've failed to get the results I'm looking for, even when courteously treated. And it is results that I'm looking for on behalf of folks who desperately need a liver transplant and other organs. Thank you.
Thank you, Senator Moran. Thank you, Secretary Azar. The record will stay open for 1 week for additional questions. The subcommittee stands in recess.